And thank you. Yeah, so welcome to everyone who's been able to join us. We'll be talking today about harnessing digital technologies for care of cancer patients, and we have two great speakers with us today. So first is, I'll just give a brief introduction and we'll have them jump into the presentations. As always, we want this to be interactive, so folks can feel free to type things into the chat, or if the speakers are okay with them interrupting with questions, but we'll certainly have time for more detailed discussion at the end. So I'll introduce both speakers. So first is Todd Anderson, who is a business analyst and software development manager at Partners in Health in Rwanda. He has worked with Partners in Health in Rwanda for several years and has consulted with 3 hospitals and a variety of clinical programs on analytics and electronic medical records to support process improvement in clinical management of patients, as well as decentralization and digitization of patient care. He also consults with the Ministry of Health on software strategy and road mapping. And our second speaker is Dr. John Black Kabuke. He's a medical doctor and health information specialist at the Uganda Cancer Institute in Kampala. He studied medicine at Makerere University, has a master's in science in health informatics from the Karolinska Institute, and a PhD in informatics from the University of Amsterdam in the Netherlands. He has been involved, his work involves both caring for cancer patients as well as implementation and evaluation of digital solutions. So without further ado, I'll allow them to speak. So Todd is going first. Thank you.
Thank you very much. And you should be starting to see my screen.
Yes, we can.
Great. So I'm Todd Anderson, and I'll be talking to you about how we use electronic medical records for our oncology program and in Rwanda, and especially at the Butaro Cancer Center of Excellence. So the primary purposes that we use the EMR for is to track the clinical work with a particular focus on chemotherapy administration and tracking. So our chemotherapy protocols can be many months and hundreds of orders long. So setting those up is kind of the killer app, as it were, in addition to more traditional functions of tracking the outpatient visits, laboratory records, seeing how the patients are varying over time, especially what outcomes they have, and then seeing the total quantities, more intense analytics, and even being the preparation for research. Additionally, there's a separate EMR system that's used for more things like billings, labs, non-oncology, outpatient care, and drug ordering. Also notable, some content, especially inpatient care for both oncology and non-oncology work, is currently still done primarily with paper, with just some certain content like diagnoses or diagnoses or missed visits that are tracked, done in the electronic medical record. The general workflow will be patients are intaked and then have many visits. Those visits are both tracked individually, and you can see the consultation sheet where we know what patients are expected to come and can follow up with them if they don't. The DST is one of the core information gathering items that we have. That's diagnosis, staging, and treatment that we try to do for to help understand what the core information of these patients are. And on the then inpatient side, and though we consider a lot of chemotherapy outpatient, a lot is, by American standards, more thought of as inpatient, as a chemotherapy visit will usually start the day before taking labs and continue into the evening to complete chemotherapy. And That chemotherapy is pre-ordered for the whole regimen and then ends up printed on chemotherapy templates that we'll be looking at in a few minutes. And then depending on whether the patient comes back on time, we'll be calling those patients and tracking that and producing lists of the patients to call, as well as noting the patient outcomes. And then on the right, you can see a few different types of reporting that we're doing. So that core function is our chemotherapy template. So previous to the electronic medical record, there was a big folder on paper and a folder on the computer desktops with Excel versions of this. Now these Excels are produced by the electronic medical records and include what dosing the patient should actually get based on their previously entered body surface area, following the protocol that the clinician entered at the beginning of the patient's management, depending on what changes have happened. This medication tracking can be seen in broad form, and this is a kind of an example of a about 6-month protocol that's being followed for a given patient. Additionally, there's the more common outpatient style tracking, where forms are capturing things like lab values, the physical examination, and this is following the philosophy that Partners in Health in general uses, where the clinicians will not necessarily be trained to an American standard, but the care tries to be highly protocolized, and we use things like forms to try to walk clinicians through the next steps that should happen, and then be able to mentor and improve how that works on the ground. After the clinical work happens, we do analytics on this data, and we'll meet periodically with the, especially the clinical program leads. And so on the left, we've got an orange line is what we care about there. That's the active patients. And we see that out of the total enrolled patients. So we're trying to keep an eye on our patients being lost, especially in the transfer process. And then the bars along the bottom allow us to say, well, some of the green patients are coming in versus red patients have died, or the large bar on the right lost a follow-up. And then we can look for any given disease and see how many patients do we know lived to X point in time, how many patients do we know died, and how many patients did we not end up knowing their outcomes after, say, 2 years, which is a big challenge of the program, especially as the care is given in a rural setting and the distance to travel can be very far. And to the extent possible, we want primary follow-up to be done at more local hospitals, even as we continue to check in both by phone and clinically, hopefully at least yearly on most of these patients. In addition to the more clinical side, or more clinical of diagnosed breast cancer patients, there is breast and cervical cancer screening that uses a parallel EMR, but most of the work at the health centers is done on tablets, especially to follow the national statistics individual clinical results, especially for referrals. We use a system on tablets called Musima that you see on the left. And this is particularly important to make sure that at each stage of the referral process, the information gets from the lower level to the higher level. And that includes both things like lab and the initial reports, as well as making sure that patients aren't missed and they end up getting follow-up calls. And that screening, again, follows the philosophy of walking this health center worker who might only get one training a couple of years ago for a couple of days on how to do the clinical work. And then they would be following through on that in their individual health center, doing work on these tablets over time. So that's the quick outline of how we use electronic medical records for oncology care through Partners in Health Rwanda and the Butaro Cancer Center of Excellence. And so you see that it both emphasizes some very practical parts of clinical care and then tries to improve the programmatic work by walking people through it, giving analytics, and letting us iterate over time. And then I think John Black is next to give a little more of the Uganda and research perspective. John Black?
Right. Thanks, Todd, for the practical insights on your experiences. If you would stop sharing, and then I can share my screen. I will give a more general, as Dio called it, more didactical side. So not only for Rwanda, but looking at what's happening elsewhere. Let me know if you see my screen.
I see it well.
Great. Good afternoon, good morning, good evening, everyone. My name is John Black Kabuche. As I was introduced, I'm a doctor at the Uganda Cancer Institute in Kampala, and I'm also completing my PhD in medical informatics at the University of Amsterdam, focusing on digitalizing oncology in Africa. So this is the perfect topic to be discussing. So I have slides, and I think they will be shared out. And in there is like 3 separate things. One of them being a general overview of digital health in Africa, or in general. But there's also 2 specific projects that we've been working on, that I've been leading myself at the Uganda Cancer Institute. And I think I'll speak about one of those, and then the other can be found in the slides. So going back, this whole thing of digital health, I thought we can also begin from the very basics of what does it mean, because we hear so many different words, and if we don't understand what they're doing, for example, Todd has been talking about EMR, electronic medical record systems. What does that mean? So we have this very big umbrella term of e-health, where you are using information and communication technologies, whatever form it is, phone, computer, robots, anything you can think about to improve healthcare. So that might be sharing information for patients. It might be ordering drugs with healthcare providers. It might be collecting data for aggregation at, let's say, a cancer registry, or for HMIs to send aggregate data to the Ministry of Health. So there's a whole spectrum of things, and there's a whole range of possibilities. Digital health is a little bit bigger than that, or it encompasses more newer things like artificial intelligence and big data. Todd has talked about analytics. I know that for us, it might be that we're not going to be doing a lot of those fancy AI and big data driven processes, because we don't even have small data yet. So we have to first get data, then be able to do the AI bits and big data. Then there's the part of doing healthcare at a distance, which is telehealth. So you're using digital solutions, of course, to afford this remote consultation, remote education, administrative tasks, whichever you are doing. As long as it involves a distance, one person being far from the other, then you're doing telehealth. A subset of that is telemedicine, which is focusing on physicians and doctors providing more treatment, curative care, as opposed to, for example, telecare that focuses on rehabilitation, let's say the elderly in their homes. So that's a bit. And then there is the M-health, or the mobile health, which is, again, digital health that is focusing on using mobile devices. So phones, tablets, and I think Todd has given some examples of those. And here you can see a visual of these, how they relate from, the bigger one, which is e-health, to, telehealth, which involves distance, telecare, and then telemedicine. I think these are important for us to understand, because always, hear these words thrown around, and many of them are buzzwords. This is a different look at these terms and how they relate, where you even have, the whole bigger information economy. So you can even include banking and financial things, which again can come in healthcare, for example, for insurance. So you can have that, or you can have interventions that are looking at healthcare financing. So those, I see some names popping up here. So I don't know if I should be the one to act on admitting people, or someone is seeing on the sides to get them in. Okay, so we proceed. There's several different digital health tools. An electronic medical record system is one that Todd has talked about. There's telemedicine applications, there's e-prescribing, there is picture and archiving. For radiology, there's decision support. Some of these really overlap, and many times when you find a good electronic health record system or electronic medical record system, it can provide all these different services. But sometimes you find an independent, let's say a lab information system that is doing only that part, or a practice management system that is focusing on administration tasks like patient registration, billing, and things like that. So there is really different ways. You have these blocks and you can build different things out of each. And again, I think these are important because when you go to purchase, you get all different services and offers that you can get. And it's up to you to say, I want this part and I want this part and I want this part. Of course, the best is to have everything, but that depends on the resources that you have. There's a newer thing called Internet of Things or Internet of Medical Things, if we're talking about healthcare, where we're looking at patients being able to monitor themselves. Usually they have like fancy smartwatches. We know the Apple Watch, and now we have many Android watches where they can monitor your heart rate. Some of them can monitor even more like activity, for example, and they can synchronize this with electronic medical record systems so that we can remotely monitor you. Imagine a patient who is undergoing rehabilitation from, let's say, amputation, and you want to see how well they are performing. So that might be this is like a new upcoming area that is also important. There was a mention of machine learning and artificial intelligence, and I wanted to just put a slide there, but we can go through that you can go through that in your own time when you get the slides. There is a thing about maturity, because all these different components, they become incremental as you add more features. So usually you begin with having separate system, let's say a lab system that is separate, and then you can print out a paper form, then you go and enter that, you copy the lab data into an electronic medical record system, and then you copy the radiology report and you enter it into the EMR. That of course comes with problems because it costs time, you have transcription errors, and you have results getting lost and that. And if you improve on your maturity, you can integrate these systems so that they can communicate with each other. And so that becomes an important topic of interoperability, systems being able to communicate and speak with each other. You can make an order in an electronic medical record system, and the pharmacist receives it, and they can even check, for example, if the drugs are available before you can, before the patient leaves the room. So if you have that kind of integration, then you are getting more value out of the system as opposed to having separate systems. And then you can go on to have even decision support. So where the system, for example, can check if we are prescribing the right chemo for the right diagnosis or for the right stage, or if the patient is not allergic to this drug, or if the patient's, I don't know, GFR is not contraindicating this paclitaxel that you are giving to them. So then you get more maturity and you get more value out of the systems. And there is up to 7 systems, so you can judge where you are depending on how many services you have. That's another part. Why do we need to digitalize? I think I've given some examples already. Bit of automation, bit of collecting data for research, bit of decision support, even expanding care. So for example, if you are doing telemedicine, you can provide care, you can even provide education to people who are very far, and this ECHO program is an example of that. And then of course, improving coordination, patients getting lost to follow-up, patients who are not adhering to medicines. You can really see these, and I think Todd also gave examples of how those can happen. And this is important because, especially in Africa, we have a lot of task shifting. You have health workers who are not trained to be oncologists, providing oncology services. So they need support. Otherwise, the chances of making errors are high. So having decision support, having things that help you with ordering, things that help you with chemotherapy protocols and roadmaps, that can help improve the service even in a place of necessity or place of deficiency like here. So I want to talk about this current state. This is a paper that I'm happy to share, where I looked at what's happening out there through a literature review and a survey. This survey was done in Maputo, those who were at AOTIC in 2019. You might have filled in a questionnaire where I asked people, tell me the systems that you have and what services do they offer. And then I also did the literature review. And this is a map showing the systems that I found. East Africa seems to be doing a good job there. And remember, these are not only electronic medical record systems, but they're any implementation. Some of them are like SMS reminders for patients, or a voucher for helping patients get their transport reimbursement to come to the hospital. And all of these are digital solutions in their form, in different forms. Or a cancer awareness system that we made at the Uganda Cancer Institute. So you can see, and of course, the literature is, has its limitations, but this can give you an idea of the services that we got. I think what we found that was more, maybe a summary of what we found, is that there are many systems, but many of them are pilots. They're just starting up. They're using simple tools, SMS, phone calls. I think there were only 2 electronic medical record systems, including the one that Todd has mentioned, talked about from Rwanda, and something called DataPal from Malawi that was focusing on palliative care. But the other systems were really, there were a lot of systems that were repurposed commercial systems. So people get, for example, Microsoft Navision, which is a billing system, and they use it to store some clinical information. And I think that is also okay. You can even use a simple Excel sheet. But the more features you add, like Todd said, they used to have them as Excel sheets, and now they have made them into open EMR for a reason that then you can have more flexibility, you can have more control, you can integrate with other systems. So this is also what we found, that really systems are really at the early stage. They're using simple technologies. I'm showing you here an example of a store and forward telemedicine system that is being used at the Uganda Cancer Institute, where they capture images of pathology slides and they can consult someone who is in Seattle, someone who is in Germany, to give a second opinion on the pathology for diagnosis. There were also a lot of things on cervical cancer screening using VIA. So the images will be stored with a smartphone. They will be sent sometimes with WhatsApp, sometimes over email, sometimes with dedicated apps like ODK. And I think what I found that is striking is that for the EMRs, there was no EMR, at least from the survey respondents, who say that their EMR met all the criteria for a standard EMR. And there's a criteria that I'm happy to share as well. Some things that we found that are affecting this are, for example, infrastructure still remains an issue, internet, electricity, and that's why things like tablets are more attractive, because you can charge them and you can use them on a battery. Most of the implementations have been funded by research grants and collaborations or NGOs, so there is no government ownership, and therefore there's no sustainability. And then many people complain about systems not meeting their needs, so it doesn't fit into the workflow, and that also leads to inertia from the clinicians. So that's a bit about the summary, and we can discuss this in a Q&A. But I wanted to talk about this system that we implemented at the Uganda Cancer Institute that was focusing on one of the important interventions in cancer care, which is awareness. We all know the challenges of lack of awareness means people don't come to care early, means people abandon their treatment. People have lots of myths and they refuse some services. For example, biopsies are very scary for people in Uganda, and I think in other places, because they think it's going to make the cancer go wild. We also have people who say, we have even some words like radiotherapy in Uganda. It sounds like you're going to be roasted, and so that makes people very scared. So what we did is to set up a service where we can explain these terms and preempt their fears. So that's a system that we did with following user-centered design. The system is an automated telephone system. When you call your bank and say, thank you for calling bank XYZ. If you want information about this, press 1. If you want information about the other, press 2. That's basically what we're doing for healthcare as well. So we have pre-recorded information translated in 7 different languages, because Uganda speaks up to 54 different languages. So we want to try and translate in multiple languages. And it's available 24/7. And we cover different topics. As you can see, this is an example of the English tree, but there is more other trees here going to different languages. We cover things like, signs and symptoms. What causes cancer? What are the common cancers in Uganda? What do you expect when you go to Cancer Institute? Will you pay? Will you not pay? How long are you going to stay in care? so that because this information is important for people to plan when they should go, if they should sell their land before they go to the hospital, if they should call their nephew to come along with them, all these different things. And of course, there's also issues around side effects, treatment, and all those. So that's the tree that we developed, of course, after involving users. And then we implemented it. This paper evaluated it after 6 months of go live. It's still going up to today. But at that time, when we evaluated it after 6 months, we had received around 2,500 calls from almost 1,200 unique numbers. And I think what was more important is to see, for example, how many people make calls on Sunday and Saturday, because that's the time when they would otherwise not get care. And now we are able to provide them this service on a weekend, which would otherwise not be possible. Or people who are making calls at 3 in the morning, at 2 in the morning when they would otherwise not be able to get service. And this timeline of calls shows the importance of advertisement. So telling people about the service increases their knowledge about it and their demand for these services. I wanted to tell about AI as the second, rather telehealth and artificial intelligence as the other project, but I'll skip through that and go to the discussion. And then we can go through these later. So really, what do we get from this presentation that is like so rapid? I'm sure you have like several questions, but I think the first one is that we get a sense of where we are today and the challenges that we're having. So we have many projects that are starting. They are using simple tools, but there's possibility for improving. And we can get inspiration from other places. We can even get collaborations. We can go to Todd, we can go to John Black from the UCI, and we can share our experiences and even maybe reuse solutions, okay? For example, the content that we use for the awareness service, we can happily give it to anyone else who wants to use it and translate it into Chechewa or into Kiswahili or something like that. We also, I think it's important to get stakeholder involvement. That one came up as an important thing, and change management and expectation management. People usually think the systems are going to do all the work, and they don't discuss the challenges that come along with it, the extra effort that you're going to put in as you are trying to get a system in place. So this is important to also think about. And it's also important to not try to aim for things that are beyond the context. So if you are trying to get robots to provide palliative care, or to get robots that can move through the hospital and bring medicines or take temperature, I think then you are really going beyond what is within reach. It adds value, but maybe you should start with simple mobile phone solutions that can help patients get information that they need, that they can get, for example, SMS reminders of when they should return, because there you are solving 80% of the problems with 20% of investment. And then you should think about the advancement and using more fancy features as you go along. Of course, that's important because while systems grow, they need to speak to each other, they need to be more interoperable, and that has to be thought about. Socio-technical issues, I've talked about those. Electricity, internet, so having infrastructure, and this is something that you cannot solve, but the government usually has to solve. Or for you, you have to think about solutions that fit within the existing infrastructure. Getting other services in cancer care, digital solutions won't solve everything. You need human resource, you need drugs, you need, all these things have to be in place. And then digital solutions can just make these things more efficient and more, they give you more value. And I think the other thing that hasn't been there is the fact that we don't have a lot of evaluations. So when I tried to do the literature review, it was very difficult for me to find a lot of information about the work that Todd is doing, for example. And a lot of information, I got it from interactions with people. It's not being published. And we don't get to know if we don't have a lot of literature. So we don't really know. People don't know if they should invest in these services if they're not being published in scientific literature. And then I think the last part is that those that have published have been focusing on evaluating usability, evaluating feasibility, without really evaluating clinical outcomes. Have we really had an improvement in survival because of these digital solutions? Have we had a reduction in late diagnosis because of these solutions? These questions are still pending, and we throw them back to you to study and publish about. I think I went so fast. I hope it was clear. I want to leave some time for questions. And so I will stop here and then we can go into the discussion. Thank you.
That's excellent. Thank you very much for those two presentations. So we'll open it up to questions. I can start with asking some questions while other people can also, interrupt and ask questions or type in the chat box. So a couple of questions, which I think can go to either of you. One of the things that came up as you guys were speaking were sometimes there are multiple systems, say like in the same institution, or multiple systems, say in a country or whatnot. Sort of what are your thoughts about how to integrate, like integration across systems? Because I can imagine that's something that will become a challenge in the future as there's more and more use of e-health and electronic systems. So that was one question. And then the second question sort of dovetails from Jean-Black, what you were saying with regards to evaluation, and just maybe opening it up to the group with regards to what folks think about ways of potentially evaluating some of these electronic medical record systems or other types of digital solutions, specifically with an eye to its outcome evaluation, economic evaluation, things like that, that actually show the actual impact of these solutions. So those are two questions we can start with, and either of you can start with those.
Well, I can start since I was, or maybe Todd, you want to go first?
Sure.
Yeah.
So I'll address a question of integrations, and I just put a comic in chat, and the timelines involved are really interesting, are really important to consider when talking about this. So the first point in time is when systems are first being stood up. I've been at the edge of a number of times where people have said, we want something that can just go very quickly. And there's often not so much thinking on, is this the one to just start up quickly that should be consistent with the future or should not be? For example, many of the Excel items to start up with, great, start that up quickly. Many times that you, on the other hand, create a new system, and then down the road, it becomes more and more work to go back and do integration. And so at this point in time, those two systems at our cancer center that I was talking about, like for billing and lab versus clinical oncology, that's a big piece of work, a significant political question on data sharing, and it would be a very large piece of work to do data integration between those two systems. We're talking probably many hundreds of hours. And then on the very long term, those of us on the software side, there are groups working for some standardization between these systems on using standards like FHIR or HL7 to communicate, and then go through significant but much easier exercises that are primarily mapping in communication between them. So these 3 points in time at the beginning, just using some Excel, great. When picking a system, trying to make sure they're integrated. At these points in time where we're a little more mature, the costs are very high. And then in the future, after central groups have done some of the standardization work, the costs get lower again. Jean-Black?
Yeah, thanks, Todd. I'll add onto this issue of integration and interoperability, which is very, very important because you get more value, as I showed in that slide of the maturity model. At level 5, level 6, level 7, you want systems to be speaking to each other so that you can get more value out of them. The first thing is that interoperability of systems depends on interoperability of the people. And that's a thing that normally gets ignored. Because why should I try to make a system that, I mean, usually you get systems from different people, from different organizations. And before these two can speak to each other, their systems cannot speak to each other. So that's usually the starting point. The workflows have to be interoperable. That the same way we do care provision at Botaro is the same way we do it at the Uganda Cancer Institute. And therefore we can get their chemotherapy protocol and use it at the Uganda Cancer Institute. And so if we build a system that speaks or goes the same process, it will be usable at the Uganda Cancer Institute. So this thing that Todd has talked about, standardization, using standards, there are a lot of standards at the data level. So for example, the data dictionary, like SNOMED-CT or ICD-10 for defining diagnoses, that is at the data level, defining diseases. But there are very few standards at the process level and at the people level. And we need to do a lot of those. I think the way to approach that is leadership. Getting a top-down approach. The Ministry of Health, and now there is for example, cancer care in East Africa. The Uganda Cancer Institute is the East African Oncology Center of Excellence, and should have the responsibility to say, this is how we're going to define documentation. This is how we're going to define workflows. Of course, that's a bit difficult to push to other places, but if you show value, then other people will adopt the same process, and then they can have systems that are interoperable. And then they can take the standards in the workflows, in the diagnosis process, in the protocols, and then you can have systems that can actually speak to each other. That's what I would say. I don't know if there were questions about the evaluation. Yes, I want to re-echo the fact that we don't have a lot of evaluations on cost effectiveness, for example, and on clinical outcomes. And I think this is something to do with the piloting nature of digital solutions. There's actually a word, pilotitis, to describe this problem, that we have a pilotitis going on with digital solutions. Because people get a grant for 1 year, for 2 years, and then they go and set up a system without regard whether another person has done a similar project. And again, if we have good leadership at the ministries of health, at the research ethics committees, for example, they can say, you know what, you are doing a thing that someone already began. Why don't you build onto what they've done, do something else? And again, and also having these publications, they help people when they're writing down protocols and interventions, that they know what's already being done, and then they know how to build onto that so that they don't repeat. So I think those are important things. The repetitions, the evaluations, people are always just starting up. Everyone is just starting from ground. And if they know that this is a question, in the Open MRS community, there's been an evaluation working group. I don't know if Todd has seen some chats around that, where we're trying to put a catalog of questions that are pending answers, of course, coming in from the Open MRS side. And questions that we can say we've answered them. So we even put the literature in a repository and say, these are the things that have been studied. And these are the things that if you're a student doing your master's, if you're a PhD student, you can work on these. And then maybe with that, we'll be able to take it to having more evaluations onto clinical outcomes or on economic evaluations. Thank you.
Thank you. Any other questions from others? I could keep asking questions if there are no other questions.
And John Black has his discussion questions on the slides, and I put some proposals in chat as directions we can go. Yeah.
So one question, to your point of pilotitis. So the awareness pilot that your team did in Uganda, I sort of wondered, is it, so do you, like, why do you think we're in this pilotitis situation? Is it the lack of funding for more large-scale implementation? Is it the lack of funding for evaluation after implementation, lack of interest? So like, how do we solve our pilotitis diagnosis?
On my side, I see two big things here. So one, where the research funding is, and it costs a lot less to do a relatively small pilot. Two, on that funding side, the relative reticence of certain funding groups to go for full scale and assuming that ministries will just pick them up. And three, something that is a major cost that we do at Partners in Health of saying, okay, we're going to both pilot it and then we'll be implementing this and iterating on it often for years before our successful scale-ups have come. I think is a helpful example. In the HIV case, it was 4 years for the initial work and then really more like 7 until big scale up. For non-communicable diseases, it was closer to 10 years of iterating before a lot of the hospital work happened. For mental health, it was about 5 years. So the timescales involved in a lot of the pilot project work are not the timescales involved in program pickup, even in Rwanda, which is probably quicker on this than most countries.
Yeah, I entirely agree with Todd about the role of funding. The funders are usually running things for a couple of years and then they go away. It's because, in Rwanda, there's Partners in Health that has been there and continues to be there, and they keep things going. For the projects that I've been involved in, I got funding for 1 year, for 2 years maximum. And the things that the granting agencies is interested in are a little bit different from what the scientific community is interested in. They're doing things at monitoring the program as opposed to monitoring the clinical impact. So, they say, if you say you train nurses and you've trained them, that's okay. Whether they're doing a good job, the assumption is that if you do the process properly, the outcome is a given, but many times that's not the case. And yet the funders, the development agencies, USAID, CDC, SPIDER, they are focusing more on the program and not on the clinical outcome. And I think ministries of health and governments have to put their foot down and say, we are not going to, we're going to sort of influence the things that you come and fund, and we shall tell you a little bit of, this is what we have in place, and this is the thing that you can pick up on. And now, if they don't have, if the Ministry of Health doesn't have, if the Ministry of ICT or the hospitals don't have this kind of agenda, then they can't really give direction to the funders, and then the funders just start new things every time. We are getting better, and I hope that this Center of Excellence in Digital Health, which is at Rwanda, which is in Rwanda, will also help in that, and having these sort of high-level bodies. For example, the East African Digital Reach Project. I don't know if you've heard about that. It's part of the East African community that is trying to push for role of digital health in research. And I think bodies like these can help the governments, and they can collaborate and build roadmaps for how implementations can happen. It's also supposed to help with interoperability across the region, having systems and people being able to move across regions, and they have their clinical records and things like that. Right?
Yeah, to talk about my own, keep going.
No. I was saying if there are any other questions, looking at the chart.
But to talk about my own failure on that for a moment, the biggest evaluation I was involved in that involved taking Partners in Health proposals, integrating them in Ministry of Health, looking at changes over years with big CDC funding, serious statisticians and clinical researchers behind it. We ended up on multiple sides having large turnover, especially of leaders that make those long-term investments that I was talking about being important as going from piloting to iteration to eventually being scaled up, that there's a lot of risk and continued commitment that needs to be there, or else it can end up with much more expensive failures like I was involved in on that evaluation side.
So we have some comments just appreciating how good a discussion and a good presentations you guys have given. So I can ask any questions from anyone?
Can I actually ask one person who has commented, Annette, because she was leading this work on standardizing cancer registry, because this is the point we're talking about, having standards across organizations and across people. And that enables us to share data across regions. The African Cancer Registry Network has been trying to get that across the entire continent. And Annette was involved in the East African Cancer Registry Network. Do you have, Annette, do you have a comment on how far we are going? Do we have a standard data set, a standard data definition for now? Or any digital solutions coming up, or we should get hold of Todd today so that makes that happen?
Was talking
it
about
appears,
this
unfortunately, that Annette has dropped off. She might have left the comment and then had to leave the meeting. Apologies, John Black.
Yeah, I think she dropped off, unfortunately. Yeah. Yeah, but that's a great example, because I think there's definitely been a fair amount of success with regards to having standard forms and standard materials that they've used across the different registries. And there's also been some success in collation of data across different registries, such that you can say stuff across registries. I don't know all the details, but I think that's been, but I know that they have had some publications along those lines. So, yeah. Yeah, so I think we're sort of getting towards the end of our time. If there are any last questions or any last discussion points, I think I'll allow the speakers to sort of, in your own opinion, and like, where do we go from here? If there were, say, like one or two key things that you wanted us to sort of like do, or a mission or something, it's like, what are your thoughts of, what are some one or two key things of where we go from here?
Should I start? I think for me, what's important is collaboration, having, knowing what other people are doing and sharing knowledge and resources will go a very long way in getting us. Sometimes it's difficult to start because you don't even know what will work for you. You need to see how other people are using solutions. Sometimes we might think it's too complex. So I think that's important. We need to do it. Of course, we need the skills. We need the tech skills. We don't have a lot of people doing informatics work. And many times you have a big divide between the geeks that are developing solutions and the clinicians who are going to use them. And then these two don't speak, or when they try to speak, they don't understand each other. And then nobody asks for the solutions because they don't even think that these solutions are there. So I think maybe one approach to this would be to bring, already like in medical school, at nursing school, to begin to bring these solutions, to give them as part of the curriculum, so that people already opened up to these ideas, and the other way around in information science schools, for people to be exposed to clinical problems, so that they can apply those. There's a lot of developers who are writing websites because that's the thing that they know. They see it every day, and they would be very happy addressing clinical problems or financial problems. So I think that will be helpful. But yeah, collaboration and getting people exposed. To me, I think that will take us far.
Yeah, and I'm thinking of some of the most valuable points of at small scale often involve the contact points with patients and getting them to come back or be referred. So that might be like these tablets at screening points. That might be lists of patients to call. That might be automated SMS. That might be just working with the clinicians to make sure, yep, you are very clear with the clinician or with the patients on what's coming next. So those with technology are often the smallest actions with the most valuable effects. And then as we look a little bigger, saying what Partners in Health has done that's been very strong in general is to say, this problem is really difficult. What are all the things that are needed in, say, XDR-TB? And it's like, oh, you need these big drugs and big trainings and lots of funding, and you might not be able to go as far. When we're looking at, in the oncology space, saying, okay, what we need pathology, we need lab, we need imaging, we need chemotherapy, and we need some systems of data tracking because the complexity of care is very broad. And then as we're thinking about implementing these systems, being both ready to look at, okay, what's it take to get a certain function done? And so these collaborations and making sure, yep, we get not just the cancer registry, but get it to really work with like FHIR standards. And then next, as we're working with clinical, acknowledge that, well, and unlike what I said 10 seconds ago, there's no such thing as done. And once we get some level of work, then that means we can get build other levels on top of it. Once we have chemotherapy, then we could do analytics tracking. Once we have analytics tracking in outpatient, then we have better access to things like SMS. When we have analytics in outpatient, then that puts us in better position for screening. And so to know that these pilots should end up being parts of systems that build on each other, and those combining effects are where the biggest benefits in the long term lie.
Okay, thank you. So I think, thank you guys for those great presentations and excellent discussion. And I hope this spurs collaboration within this group as well, and also spurs folks to write about what they've done so that it can be shared with the broader community, and sort of like work together to enhance people working together and then systems working together in the future. So on that note, I think I'll turn it over to Charles and Mishka if there are any announcements for the group.
So thank you very much, Dio. And I would like to thank our speakers for today, Todd and John Black, for very informed presentations. And I would also like to thank our participants who've managed to join us today. So we are going to share the recording after this and also the presentations that were shared. So look out for that. We normally share through Basecamp. And if you're not on Basecamp, you can reach out to Mishka so that you can be added there. Then our next session will be held 2 weeks from now, which will be on 17th of March. And we are going to continue with the discussions on digital health, where we are going to be looking at harnessing digital platforms in cancer survivorship care. So please plan to join us. So we are going to be sharing the agenda soon. Look out for that. And please plan to join us then. So I'd like to hand over to Mishka and Amaka if they have anything to add. Thank you very much.
Thanks, Charles. Thank you again, Todd and John Black and Dio very much for great facilitation of the discussion. I personally learned a lot, so definitely look forward to continuing this. Amaka, over to you.
Thank you, Mishka. Nothing much to add, except that I think this was a very, very illuminating session for me in particular, and I'm sure the people on the call really enjoyed it. So thank you so much to Todd and John Black, and see you next week. To everybody on the call, as we'll be continuing, like Charles said, more talk around digital health, but this time really looking at survivorship care. All right, bye.
Okay, on that note, thank you guys. Bye.
Thank you. Bye.